Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 337 of our Pharmacotherapy MCQ series, which majors in medication therapy management and assessment of therapy.
The next question reads, TMC is a 76-year-old woman who comes to an appointment at the community pharmacy with her daughter for a focused medication therapy review, abbreviated as MTR. She has a Medicare Part D prescription drug plan and is asking for help with her medication costs. She indicates that she has type 2 diabetes mellitus, hypertension, back pain, and hyperlipidemia. Her medications include lisinopril 40 mg once daily, metoprolol 50 mg twice daily, glipizide 5 mg once daily, indomethacin 50 mg up to 3 times daily as needed for pain, and rosuvastatin 40 mg once daily. TMC tells you that she has trouble paying for her rosuvastatin, that is Tier 3, $60 copayment, and would rather have something generic that costs less, that is Tier 1, $5 copayment. Further, she complains of muscle soreness and weakness during the last 3 weeks. What is the primary problem? What objective information can be obtained in a community pharmacy setting? What additional information is necessary to determine the cause of her problem? How would a clinician assess and document her problem or problems in a SOAP format? Although the patient presented for a medication therapy review, the primary complaint is the patient's self-reported muscle weakness and soreness during the last 3 weeks. Assuming that TMC is a patient of this pharmacy, the practitioner could gather the necessary medication history from the PIS. Because the patient is present, this is a good opportunity to develop a personal medication record, abbreviated as PMR, with TMC. This process will help to quickly identify any medication discrepancies between the pharmacy computer system and the patient's understanding of medication administration. If discrepancies are noted, the practitioner can clarify them with TMC right away as part of the intervention. The personal medication record should also include a section to list medication allergies. The type of reaction should also be included on the personal medication record so that other providers will know the severity of the medication allergy, i.e., intolerance versus anaphylactic reaction. Based on the data gathered from the pharmacy computer and TMC, a personal medication record could be developed. Reviewing the medications alone often does not provide enough information to determine whether TMC is experiencing a medication-related event. Further questioning related to the onset of her symptoms of muscle soreness and weakness may help to determine whether this is a medication-related problem. The practitioner can develop an assessment from this questioning and the personal medication record of the current problem that she is experiencing. As indicated on the personal medication record, TMC started rosuvastatin most recently. The initiation of this medication corresponds to the onset of her recent soreness and weakness. Beta-hydroxy-beta-methylglutaryl-CoA, abbreviated as HMG-CoA, reductase inhibitors like rosuvastatin are known to cause myositis, or muscle breakdown, which may lead to weakness and muscle soreness. Furthermore, the prescribed dose is high for a woman of TMC's age. Based on this information, an assessment of the problem can be pursued. If rosuvastatin is the suspected agent, the plan would include actions necessary to solve the problem or to determine whether rosuvastatin is the cause of her muscle soreness and weakness. Unfortunately, not all of the necessary information is available, e.g., her baseline cholesterol, serum creatinine, liver function tests, or creatine kinase levels, to develop a formal plan of action to resolve the adverse medication event. However, part of the plan may be to obtain the laboratory test results necessary to identify or act on the adverse medication event. An example of the documentation of the SOAP note follows. Regarding the primary problem, it is muscle soreness and weakness, which is a possible adverse medication event. Subjective information includes the fact that TMC reports weakness and soreness, predominantly in her legs, during the past 3 weeks. She has difficulty rising from her chair after sitting for long periods and describes the pain as aching. The patient reports taking her medications as prescribed and rarely misses a dose. Objective information include total cholesterol of 137 mg per deciliter, and LDL cholesterol of 56 mg per deciliter, and HDL cholesterol of 54 mg per deciliter, triglycerides of 136 mg per deciliter, a body temperature of 98.5 degrees Fahrenheit, and a blood pressure of 144 systolic 68 diastolic. Regarding the assessment, TMC has muscle weakness and soreness in her large muscle groups. According to the American College of Cardiology and the American Heart Association, TMC is considered to be at risk of heart disease because of her age and concurrent disease states. Her current lipid therapy is rosuvastatin 40 mg once daily, which was started by her cardiologist 6 weeks ago. The initiation of rosuvastatin 40 mg correlates to the timing of her muscle soreness and weakness. HMG-CoA reductase inhibitors, i.e., rosuvastatin, are known to cause myositis or myalgias, and this patient is at particular risk given her age, sex, and starting dose. It is possible that the rosuvastatin could be causing her muscle soreness and weakness. Other lipid-lowering agents could be tried, or the dose of rosuvastatin could be reduced, which might eliminate or reduce this adverse event. A creatine kinase level should be obtained to determine the severity of the myositis. A serum creatinine should also be measured, as myositis can lead to renal damage and rhabdomyolysis in severe cases. However, this is usually accompanied by fever and other symptoms that the patient is not currently experiencing. We will now look at the plan. Regarding the drug-related adverse event, the following is an example. 1. Discuss the possibility of an adverse medication event with the patient, which included the signs and symptoms of myalgias and myositis. 2. Contacted Dr. Hart, that is TMC's cardiologist, to discuss the current problem with rosuvastatin. 3. For discussion with Dr. Hart, will obtain a creatine kinase level and serum creatinine. 4. Discontinue rosuvastatin per the pharmacist's recommendation. Dr. Hart agreed that TMC should temporarily stop her rosuvastatin until her laboratory values are reviewed. 5. Alternative dosing of rosuvastatin 5 mg or another equivalent agent, atorvastatin 10 mg or simvastatin 20 mg, was discussed with Dr. Hart. 6. TMC is to see Dr. Hart in the cardiology clinic in 2 days to discuss the laboratory values and alternative therapies. 7. Discussed the entire plan with TMC, and she verbalized understanding of steps that she is to take with respect to her current medication-induced problem. The next question reads, from TMC's medication profile, what other problems can be identified with her medication therapy? What can be done to address these issues? There are two remaining issues that may need to be addressed. The first issue relates to the pain medicine, that is indomethacin, that TMC is taking. It is suggested that indomethacin may have a higher rate of central nervous system side effects in the elderly compared with other agents in the same class. Furthermore, the American Geriatric Society guidelines on the management of mild to moderate persistent pain caution the use of nonsteroidal anti-inflammatory agents in older adults, preferring acetaminophen as a first-line agent. Other prescription medications or non-prescription medications such as acetaminophen alone could be used to help treat TMC's pain. Second, it is not clear from the current information whether the various providers are communicating. It is the responsibility of the pharmacist to help coordinate care among multiple prescribers as described by the APH-AMTMS consensus document. Therefore, it is important to be sure that both providers, Drs. Smith and Hart, receive a copy of the documentation of the issues addressed during the visit. SOAP note. The next question reads, what additional information can be provided to TMC at this time? Finally, TMC came into the pharmacy asking for help with her medication costs. To assess this problem, it is important to ask whether there are specific cost issues with a particular drug or whether it is her overall medication regimen that causes her concern. Another question to ask is whether she has stopped taking any medications or changed the way she takes them because of cost. Many patients will discuss cost and adherence issues with their pharmacist, because the point of sale for medications occurs at the pharmacy. However, they may not discuss this problem with the prescriber. Cost and lack of adherence because of cost are medication-related problems that the pharmacist must communicate to the prescriber on behalf of the patient. In assessing drug cost, there are several steps that can be taken. First, determine the patient's ability to pay for medications, implement low-cost, medically appropriate interventions targeted to patient needs, facilitate enrollment into relevant benefit programs, and confirm medication changes with the patient and prescribers. For TMC, the rosuvastatin is her biggest concern, as it costs $60 per month and her Medicare Part D plan lists it as a non-preferred, that is Tier 3, agent on the formulary. With the possible discontinuation of her rosuvastatin, it is important for the pharmacist to anticipate an alternative lipid-lowering agent and determine a cost-effective alternative that may be appropriate. This information can then be relayed to the prescriber. Furthermore, the alternative lipid-lowering formulary choice can be integrated into the plan developed for the primary issue of muscle soreness and weakness. The integration of multiple problems is a complicated but an important aspect of the medication action plan. As discussed previously, an important part of MTMS involves the medication action plan. The Medication Action Plan is a document that may empower the patient and promote self-care. The information on the Medication Action Plan is important for both the patient and the provider, and it facilitates communication among multiple providers. When a patient presents the PMR and Medication Action Plan to all providers, complex medication information can be shared across the continuum of care. Because extensive information was communicated to the patient and other providers, follow-up, that is phone or face-to-face, would be appropriate and necessary to determine the resolution to the medication-related issues identified. Follow-up should occur in a timely manner, likely after TMC has obtained the necessary laboratory test results and has been evaluated by her cardiologist as outlined in the plan. The follow-up should include questions related to the changes that were or were not made based on the practitioner recommendations and any new issues that have surfaced. Follow-up should be considered after any encounter in which an action plan is developed to determine whether the medication-related problem has been resolved. Additionally, problems may be identified and prioritized during the initial visit but, because of time constraints, may not be addressed. A follow-up visit allows for assessment of these problems. The next question reads, assuming that the pharmacy provider had an NPI number and a contract with TMC's Medicare Part D prescription drug plan, how could the 30 minutes spent with TMC be billed to her insurance? Provided that TMC was identified by her Medicare prescription drug plan as eligible for MTMS, the practitioner could bill for the 30-minute encounter. Using the practitioner's NPI number and the appropriate CPT codes, the practitioner could bill for one CPT 99,605 for the first 15 minutes of initial face-to-face MTM encounter and one CPT 99607 for an additional 15 minutes spent with the patient in a face-to-face MTM encounter. TMC's Medicare Part D plan may require the practitioner to bill the prescription drug plan initially, and then the plan would pay the community pharmacy directly instead of reimbursing the individual pharmacist. Documentation of the visit would need to be stored at the site of the encounter in case any information was requested from TMC's prescription drug plan. The next question reads, TMC has just been hospitalized in a large medical center for renal failure and urosepsis. The pharmacist has access to the medical chart, nursing record, MAR, and a computer that directly links to the clinical laboratory. The pharmacists at this facility assess the patient's drug therapy and routinely provide clinical pharmacokinetic monitoring. How would the pharmacist approach TMC differently in this inpatient setting compared with the pharmacist in the previous question who worked in a community pharmacy? Similar to the outpatient setting, the SOAP format is often used when documenting the encounter of the hospitalized patient. However, obtaining the information needed poses unique challenges. In this setting, subjective information may be more difficult to obtain at the time of assessment in those patients presenting with cognitive impairment resulting from their acute condition, such as the seriously ill or injured patient. Objective data, on the other hand, are more readily available and retrievable with access to pharmacy, laboratory, and other medical record information. On admission to the healthcare facility, the medication reconciliation process should be initiated to identify any variances in the admission orders when compared with the patient's home medication list. With acute medical problems superimposed on chronic conditions, it is not unusual to have new medications added and home medications held, changed, or discontinued. Assessing the appropriateness of drug therapy requires a basic understanding of both pharmacokinetic, e.g., absorption, distribution, metabolism, and elimination, and pharmacodynamic, e.g., relief of pain with an analgesic or reduction of BP with an antihypertensive agent principles. This detailed assessment and monitoring is dependent on the availability of robust patient and laboratory data. The inpatient setting is a relatively data-rich environment in which access to needed information is readily available. Knowledge of the patient's height, body weight, and hepatic and renal function are essential for proper dosage considerations. The type of hospitalized patient will vary from the short-stay elective surgery patient to the critically ill hemodynamically compromised patient. The pharmacist must be aware of how pharmacokinetics and pharmacodynamics can be altered throughout the hospitalization or disease state process in each patient evaluated. This heightened awareness will allow for timely interventions and minimize medication errors resulting from improper or delayed dosage adjustments because the clinical status of the patient changes. Drug level monitoring may be suitable for certain medications and is of great clinical value. Nevertheless, it is important to take into consideration clinical response to drug therapy along with the assessment of a specific laboratory value. Accurate interpretation of any drug level requires review of the nursing MAR, or EMAR, evaluating time of drug administration to serum sample acquisition. When serum drug levels are obtained, they must be reviewed for validity before alterations in medication regimens are made. If a serum drug concentration seems unusually high or low, the clinician must consider all of the various factors that might influence the serum concentration of the drug in that particular patient. When the reason for an unexpected abnormal serum drug concentration is not apparent, the test should be repeated before considering a dose change that may cause supratherapeutic or subtherapeutic concentrations resulting from erroneous data interpretation of clinical laboratory tests. When TMC was seen in the community pharmacy, the pharmacist assessed her chronic conditions, her cost issues, and her drug therapy. Monitoring in the community pharmacy-based MTM program occurs at regular time intervals and is less sensitive to the day-to-day changes of the patient. However, in the inpatient setting, TMC has acute conditions, renal failure and urosepsis, in addition to her chronic conditions. Monitoring of medication therapy will occur frequently, resulting in a dynamic treatment plan for her acute and chronic conditions. Although the inpatient setting is relatively data-rich, the information gathered and the assessment and plan formulated in the facility must be communicated to other providers once the patient is discharged. At discharge, it is critical to ensure that the patient has follow-up with his or her primary care physician or coordinated care team in a timely fashion. At this point, it is again critical for the pharmacist to perform medication reconciliation to determine exactly what did happen once the patient returned home. This closes the loop at a critical time when the patient is prone to medication errors and readmission. Let's briefly discuss medication therapy management and pharmacogenomics. The use of genetic information to predict an individual's response to a drug, known as pharmacogenomics, is currently factoring into drug design and development. Using genetic information to tailor drug therapy to an individual will reduce the risk of adverse events, potentially improve patient outcomes, and create a more efficient drug development process. By transforming drug therapy into a patient-specific approach, the healthcare community is one step closer to achieving the new medical paradigm of personalized healthcare. MTM can be the vehicle to allow pharmacists to serve an integral role in applying pharmacogenomics into clinical practice to improve the quality and safety of healthcare. Incorporating pharmacogenomics into MTMS allows pharmacists to lend their expertise to the treatment planning process to optimize treatment outcomes. Pharmacists, working collaboratively with prescribers and laboratory facilities, could review medications prescribed for a patient as well as the patient's genomic data to then offer an assessment on whether a prospective drug would provide the best fit for the condition and patient. Through MTMS and pharmacogenomics, pharmacists can optimize drug choice and maximize therapy outcomes. In order to successfully integrate a pharmacogenomic component within the clinical decision-making process, key pharmacogenomic data must be identified. The challenge is complex, and research has begun to bring the application of pharmacogenomics to patients as part of the healthcare delivery system. The pharmacy profession must define a process for the application of pharmacogenomic data into pharmacy clinical practice that is aligned with MTMS delivery. A viable business model should be developed for these practices that encourages and promotes the use of the clinical expertise of pharmacists working in collaboration with other healthcare providers and laboratories. The development of technology solutions that support the pharmacist's role in this emerging field should also be encouraged and directed. In conclusion, MTMS are intended to be applicable to patients in all care settings where the patients or their caregivers can be actively involved with managing their medication therapy. The goals of all pharmacists providing MTMS are to confirm that the patient's medication therapy is ideal and that the best possible outcomes from treatment are achieved. The MTM process needs to be properly documented and accurately shared with all providers that are part of the patient's health care team. As drug therapy and technology options continue to evolve, pharmacists are encouraged to provide and optimize MTMS to improve patient outcomes and medication use.
So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 338.